to the available prevalence data. As secondary outcomes, we will compare the performance of the 3-ounce water swallow versus imaging-confirmed dysphagia, and also compare markers of pneumonia severity, oral function, dietary intake, and frailty between those with and without dysphagia. In terms of our methods, our inclusion criteria is any adult age 65 years or over who presents to the emergency department and meets our clinical criteria for pneumonia diagnosis, as outlined here. Essentially, we require them to have at least 2 signs or symptoms of pneumonia, one of which must be respiratory system specific, plus they have to have chest imaging suggestive of pneumonia for the attending radiologist impression. We exclude any patients who are critically ill, as they would not be able to participate in study procedures during their emergency department visit. As seen here, our ED study procedures include saliva collection for analysis of flow rate and pH, a 3-ounce water swallow test, and the EAT-10. Once patients have recovered from their acute illness, we bring them back for an outpatient videofluoroscopic swallow study so as to try and replicate their pre-pneumonia swallowing function to the greatest extent possible. In terms of results, here you can see that we've currently enrolled 17 of our target 55 subjects for the pilot study. Of the 17, 7 have already come back for their follow-up VFS study, 1 is withdrawn, and 1 was deceased prior to follow-up, with the remaining 8 subjects being actively scheduled for their videofluoroscopic swallow studies. The average age of our cohort is 73.8 years, and it is predominantly white, as is consistent with our local hospital demographics. Over 75% of our cohort was admitted, which is expected, and we observed nearly all patients had an acute cough, whereas less than 20% had a fever. This is consistent with literature demonstrating the absence of fever in older adults, even when they have serious bacterial illnesses such as sepsis. In terms of our swallowing outcomes, thus far, 76% of patients have failed their bedside screening 3-ounce water swallow test. Additionally, here you can see the EAT-10, which was our selected patient-reported outcome for the study. Nearly half of the cohort thus far has EAT-10 scores greater than or equal to 3, which indicates swallowing difficulty, and nearly 1/3 have a score greater than or equal to 15, which has been reported as 71% sensitive for aspiration on VFS. In terms of the VFS results, the digest safety, efficiency, and overall scores were determined by a trained, reliable SLP. On the right, you can see the safety grade of digest as it maps to the penetration aspiration scale score, and the efficiency grade, which maps to percent pharyngeal residue. At the bottom right, here you can see a grid that enables determination of the overall digest score using a combination of the two. In terms of our results, 43% of subjects have had scores of at least 1 for digest safety and efficiency, with 57% having an overall grade of at least 1. It is important to note that only 1 of the patients identified in our cohort as dysphagic had pre-existing dysphagia diagnosis. In terms of our oral function outcomes, 40% of patients had hyposalivation and the majority had acidic saliva. The xerostomia index in nearly half of our patients was greater than 1 standard deviation greater than reported normative values for older adults. As you can see here, our study has some important limitations. First, this is a preliminary analysis with only about 1/3 of our cohort yet enrolled, and we only have VFS data completed for 7 patients as of this recording. Ours is a single center pilot study, and because of our institutional demographics, the cohort lacks diversity. Finally, as part of our inclusion criteria, we will have a 3-member expert panel independently adjudicate each case to ensure it represents an actual pneumonia diagnosis, and this process has not yet been initiated. In conclusion, our early results mirror those of prior studies suggesting a potentially high prevalence of dysphagia in older adults presenting to acute care with pneumonia. The 3-ounce water swallow test appears to be sensitive in picking up patients who go on to have confirmed dysphagia, but we will need to determine if it has sufficient specificity to be useful as a bedside screening tool. Also, oral hypofunction appears to be common in this cohort, and the relationship between pneumonia severity, oral function, and dysphagia status is an area of intense interest for our group and for future inquiry. Our next steps are to continue enrollment on the study so that we complete our primary and planned secondary analyses as outlined here. And with that, I will conclude. And I want to say again, thank you to the WGS for this opportunity. And I look forward to answering any questions you may have during the Q&A session. Thank you.
Thank you for your informative presentation. Now are there any questions? Not yet. So, can I ask you questions? Mm, you're in the emergency room, so patient transferred to you is emergent condition or some mixed with outpatient level patients.
Yeah, so we're the primary treatment site, so nobody would, very rarely are patients transferred to our setting. We're the initial point of contact for ambulatory patients and any obviously critically ill patients that come by emergency medical services. So we can see a very wide range of folks that are treated as outpatients, but also admitted and all the way up through critical care. So it kind of all comers, we take them all as they come.
So your result is a mixture of severely injured patient and mildly impaired patient.
Yes, 75% of our cohort thus far has been admitted to the hospital, so requiring hospitalization. But again, 25% are this ambulatory patients who are treated as outpatients. I think that's about what you'd expect with this older adult population with pneumonia diagnosis. But yeah, we have a mix of groups for sure.
Okay, and this prevalence rate is high or low in compare with your expectation?
My hypothesis is that currently there's a very high unrecognized prevalence in community-acquired pneumonia of dysphagia, and that's kind of the basis for the study. Is I believe that the acute care physicians and the hospital physicians even are not adequately considering dysphagia as a contributor to pneumonia development, unless they really label it as a clear aspiration pneumonia. I feel like there's you kind of alluded to this idea of a spectrum of pneumonia, but my hypothesis is, and I think there's some literature supporting this, that many of these pneumonia cases actually are unrecognized dysphagia-related pneumonia, and they're just not being labeled as such because they're not falling into the traditional aspiration pneumonia bucket.
I see. So I hope your research will change our common sense.
Yeah, me too. Thank you.
Thank you for your presentation. So now